We began to work at MRI because to look at the wall, and we did a lot of work about a few years ago in trying to identify the different lesions. I want to emphasize now a few points, which is more recent, and are concepts that have evolved based on the experience. First of all, I think nobody disagrees that we are dealing with a systemic disease. We have a lot to show. A number of people disagree here that the vulnerable plaque or high-risk plaque is an abundant phenomenon. And I will talk about this in a moment. I don't think anybody disagrees that depending on the region of the arterial system, the clot has different mechanism. That is, in the legs, an occlusion of an obstruction of the femoral artery is no plaque rupture. In fact, it's a clot on top of a plaque that is very stenotic, and maybe 1/3 of the acute coronary syndromes, and maybe carotid plaques may be very fibrotic and stenotic and be complicated by a clot. The question is here. The plaques are very abundant, and if they are, then we are lost if we go prospectively. Well, we can look at these different ways. If you look at all these studies, all point out that the number of plaques on patients with acute coronary syndromes are significant, plaques that could be dangerous. Either they rupture, they show thrombus, or they can be vulnerable. I'm constantly reminded in the last few months that this paper is overemphasized the issue. However, a few months, 2 years later, we have this other paper coming out which shows a large number, significant number of plaque ruptures in patients with acute coronary syndromes when they are looked by IVUS. I was very fascinated by the paper of Willerson and Cassels, just written in Circulation, where they point out, very interesting, they say finding vulnerable plaques, in fact this is in S. So this means they're already talking plural, which to me is an advance in the field. And I think the paper is a good one. It doesn't compromise. It compromises saying we have to do studies to see how many plaques are there. I'm going to present to you two arguments, saying to you that these plaques are very. First of all, they are very extensive. It's not just the number. And the second issue is I will show you the data that we just got, which tend to support that we are dealing more than 1 or 2 or 3. Now, the question is, this is a study just published last week with Pedro Moreno with vasa vasorum entering into the intima of the vessel. And the vasa vasorum, particularly in diabetics and in non-diabetics, not so predominant, but the concept is that teleologically these vasa vasorum have a defense mechanism. But they go along with macrophages, maybe because red cells leak from the vessels and they act as foreign bodies, and then the macrophages come in, and now you have a problem. And the problem may be that as the vessels go there to get the fat, the macrophages that are there taking care of the red cells may release substances, enzymes, and really disrupt the internal elastic lamina. I think this is a key slide. And that is in this autopsy study, when you look at the association of the types of lesions that were with plaque rupture, you realize that the least important mechanism was how much lipid was there. What was very important was the rupture of internal elastic lamina and how many vasa vasorum enter. And if you read the paper from Michael Davies, I don't have it with me now, that claims that the degree of stenosis has very little to do with the plaque rupture. In the same paper, he points out that the degree of lipid varies from plaque to plaque. And you just prospectively, it's very difficult to say I'm dealing with a vulnerable plaque while I'm not. What I'm really trying to say, this is a very difficult field if you go prospectively to say, let me find what plaque is vulnerable and let me put a stent or whatever you want to do. I think the other thing that I'm going to show you, the plaques are pretty extensive. I mean, this is not 2 millimeter plaques. It's a deposition of fat that tends to be, and the pathologists know this very well. So having said that, sure, you can, now I'd like to go into the issue of the burden of disease. And the movies are not working, but doesn't matter. You know CT of the coronary arteries. The point I'd like to make is that people using CT, and we are, to say that CT will characterize plaques, I have great questions. I think this is a physical technique based on physics which has limitations. And I think it's a great technique to look at how much lumen is there. But certainly, at least in the study we just published, is that in the animal model, it doesn't characterize the plaques like magnetic resonance imaging can do. I'd like to present now the three phases that I think are critically important in the near future to really try to advance in the field with technology of imaging. The first is to be humble and just accept the fact that maybe many plaques, and let's look at the burden of disease, which we know has significant prognostic implications I will show you in a minute. This is the group from Japan, publishing a study which is very simple, somewhat primitive in terms of technology, dividing the aorta in different segments, and then looking at how much disease is in this circle, and then giving a score, like the Framingham score that you do with risk factors. This is burden of disease, and it's appealing, it's simple, and so forth. And the results were interesting. There was some relationship to LDL on the thoracic aorta, some relationship to fibrinogen. Higher is fibrinogen, higher is the score with imaging. Some relation with CRP, age, systolic pressure, and degree of smoking. But the most important relationship in the whole paper has to do that whenever the thoracic aorta has even an average, a moderate score, this is predicting coronary artery disease. Pointing out, as I mentioned before, that we are really dealing with a systemic process. Now, this is a study that was initiated by Thahi Fayyad at our institution, and we are now accumulating patients, but it's more sophisticated than the other one because it takes many more cuts, and we are looking at the area of disease. So this is not just the perimetry of the disease. And I'd just like to point out that the patients entered into the study, which is in total of 99, these were patients in the intermediate risk of Framingham, and that is with a score of an average score of Framingham risk factor about 7 to 8, with this risk factor over a 10-year period, which is about 9 to 10% events over a year period. And this is just the age of the patient, the average, and this is the predicted events. In this study, it was a relationship between age and the area of the carotid artery, and so of the aorta. A similar study, maybe more simple than that one, is the MESA study from 6 groups, including Hopkins, where what they did is they looked at the validation of wall thickness, not area, just thickness, and trying to look at two observance, and the correlation was actually pretty good. What is interesting is this. There is no close relationship between Framingham score in this population of patients and the presence or absence of coronary disease. But there is a very good correlation in terms of the wall area of the aorta and carotids with the presence or absence of coronary disease. I think this is very important because I'm making a statement here that is, imaging has a lot to offer. In the business we are. Not all smoker develops the disease, and not all hyperlipidemics develop the disease. And the question is, can we go further and image and quantify like Framingham does? And that to me is the near future, not the ultimate future, but the near future, that we focus into what we call the burden of disease. We are actually getting into the iliofemoral arteries now, screening top to bottom. The second technology, and I'm sure Thahi is going to talk about, is the MRI has advanced profoundly in the last year, where you can use the three modalities together and come up with a color in the computer telling you what is there, and is much more expeditious, the data that you can acquire. And I think that's how we are going to get into the coronaries, which leads to the final comment I want to make, and that is how I view entering into the coronary arteries, and to talk about, I don't know what, vulnerable, not vulnerable, but really looking at tissue characterization. And this is what you mentioned through molecular MR. And it's very simple. There is a molecule, there is a peptide or an antibody with a carrier, iron or gadolinium, and then you look at events. And now comes a critical issue. Is the fat extracellular or intracellular? Is the fat this extracellular or is inside the macrophages? And what this technique shows already in the rabbit model with mice cells that identify fat, that you can see this very, very nicely, the fat here in the aorta of the rabbit model, not just by density as we looked before, but really characterizing the tissue. And here's where you begin to learn in humans and in animals, the fat is diffuse. And for example, this is a rabbit, and you say, well, a rabbit is not a human. I'm completely in agreement with that. But we have lots of pictures in humans showing the same thing. The fat is very diffuse. Now the question to you is this vulnerable or is not? Who knows? I don't have any idea prospectively. And it's very hard. And I think we have to go backwards a little bit and be more relying on the factors that we see, and then maybe prospectively we can go back to what is vulnerable, what is not. This is fascinating. This is actually macrophages that are identified also by scanning with the scavenger receptor, a mice cell that identifies this, and you see this in the vessel wall. And when HDL is injected, again attached to gadolinium, it goes exactly where the macrophages are. This is also done with immunofluorescence, telling you how powerful molecular MR is. This is the first time done in vivo, actually, that you can see, you can trace. I believe it's the first time. Maybe you, Pikesha, will tell me I'm wrong, but that you can follow the HDL exactly, you trace it where it goes. And now is the blood clots. You have here a clot that is very young, acute, 1 week, 6 weeks, 8 weeks. Mark Cirol is presenting this in this meeting. And then to follow with a specific fibrin target contrast agent, you can see the clot beautifully, and you can see how the clot tends to disappear over a period of 6 weeks. I'd like to finish by talking about the vulnerable patient, if I may. I'm just giving you a sense of how I view this field. I would be very careful in talking about the vulnerable patient. It's too complex, so many things. What you might do, if you wish, is to talk about the vulnerable myocardium and taking that and then together with the arteries. Otherwise, it's difficult. And I give you an example of that we are very interested on. You know, the myocardium, we believe, right or wrong, that MR is going to be the technique of the future in myocardium. Why? It looks at the scarring, looks at the border, looks at the microvasculature, certain ischemia in stress, non-viability and viability. And we are now beginning to work on a study which is very fascinating, which is a study looking at stem cells in the myocardium. But I'd just like to point out this project is led by MRI Dr. Rahul Palan, and this is actually in the animal model led by Juan Badimon. But just to tell you that you can look with MR in the myocardium everything you want to see in the peak that we induce myocardial infarction over a period of 90 minutes. And this is actually in humans, which is over a period of 60 minutes. And you really can go, actually, I am supposed to talk about this in a couple of days in this meeting, but I'm just pointing out to you that I think new technology will give us a lot of driving of what nomenclature we should use. I only want to point out tonight that we have to be very cautious about saying, let's see where the plaque is and let's take care of, because I think it's much more complex than that, and there are many, they are extensive and so forth. And then the other issue is, I think I would put a lot of emphasis on the burden of disease at this time, which can we correlate with Framingham. And then the final issue is that, frankly, rather than talking about the vulnerable patient, I would rather like the vulnerable myocardium, and maybe in the future we can talk about the vulnerable patient. I'm just giving you my thoughts, whether you are in agreement or not, but I think is a point of view from what I know about this particular field. Thank you very much.